I'm going to talk about exercise today and how it relates to Parkinson's disease. Here's a little overview of what we'll go through. So I know you are all very familiar with Parkinson's disease symptoms, but I'm just going to give a little brief overview of that, and some of this we've already talked about. Am I not loud enough? You can't hear me? Maybe, well, is that okay there? Okay, all right, I'll try to remember to stay close to the microphone. And we'll also talk about how exercise influences the motor symptoms of Parkinson's disease, as well as some of the non-motor symptoms, with most focus on sleep and cognition. We'll briefly discuss diet and Parkinson's disease. And then at the end, I'm just going to make some recommendations for overall healthy living. And a lot of this talk will be about research, but I'll try to include some helpful points as well. So I know you already saw some of these pictures in Dr. Woodward's talk this morning. This is a picture that was drawn by Sir William Gowers in the late 1880s, and it shows a patient with Parkinson's disease. And we've got a lot of treatments that can help it so that all these symptoms are improved. And then we also have a picture of the pathology in Parkinson's disease. And again, Dr. Woodward showed this. And Dr. Holden touched on recalling to us all the Lewy body, and that's what's pictured on the bottom right. So Parkinson's disease was first described by James Parkinson, and he really focused on the movement symptoms, and that's what we were all mostly aware of until the more recent years. And those are most importantly slowness of movement, which of course is also called bradykinesia, stiffness or rigidity, wrist tremor, and balance trouble. But then the non-motor symptoms are also very important and can really have a significant impact on quality of life. And those include things like sleep problems, cognitive impairment, autonomic dysfunction, which means getting lightheaded when you stand up, constipation, urinary and sexual dysfunction, hot and cold, not feeling quite right. There can also be mood symptoms like depression and anxiety. And then we got to hear a great talk about psychosis and hallucinations. So let's move on to talk about exercise. So there have been several large epidemiologic studies looking at the population level on what exercise does for Parkinson's disease risk. And large studies show that if you exercise a lot in your early years and even in midlife, you have less likelihood of developing Parkinson's disease. Now, that's of course not always true. People who exercise also can develop Parkinson's, but we think that may have developed later in your life than it otherwise would have if you hadn't been physically active. And it's also true that higher physical activity levels are associated with slower progression of Parkinson's motor symptoms, as well as cognitive impairment over time. And this graph that's on this chart is what's called a meta-analysis. So there was a research group who took a collection of multiple different studies looking at how Parkinson's develops in life and how exercise might affect that. And it looked like overall, the people who exercised were less likely to develop Parkinson's over time. But unfortunately, physical activity tends to decline over time in Parkinson's disease. And this could be multifactorial. It may just be because, as your balance worsens potentially, it can be harder to get up and get physically active. There can be apathy in Parkinson's disease that can lead you to be less motivated to exercise. So a lot of different things might contribute to that. But unfortunately, physical activity does tend to decline over time. And this was taken from the Parkinson's Progression Markers Initiative that's sponsored by the Michael J. Fox Foundation. And Dr. Heffernan mentioned that study earlier. So we first did this study over 4 years of data, and then it was followed up at 6 years time point, and showing in this chart that the healthy control participants in the study maintained a similar level of physical activity over time, but the Parkinson's patients reduced activity. And so does that really matter? And we think that it does, because additionally in that later study that looked at 6 years over time, it showed that the DAT changes, so the dopamine changes in the brain by a DAT scan, actually were slower worsening in people who exercise more. Additionally, exercise can change the way symptoms are in Parkinson's once you've already developed the disease. So progressive resistance training, which is also called, things like weightlifting. In this study, they show that it had there was less progression of disease or less worsening of disease in people who did resistance training compared to people who did a stretching program. So the weightlifting group did better over time, and that's the dark line. Sorry, all my pictures aren't showing here up here. And then there was another study that looked at an intensive rehab intervention that was actually an inpatient intervention that happened twice over the course of the study. And everybody who enrolled in this study was only on one medicine when it started, and that was rasagiline or Azilect. And the people who were in the intensive rehab group, they were able to stay on just one medication for a much longer period of time, and that's that top line. Whereas the people who weren't in the exercise group had to start on medications earlier. So it suggests that exercise helps slow the progression or the severity of the motor symptoms of Parkinson's. There's also a study that Dr. Heffernan mentioned earlier called the SPARKS study, and it's the study in Parkinson's disease of exercise. And we're currently on SPARKS 3, but the original studies were SPARKS and SPARKS 2, and they showed that there were improvements in motor symptoms with high intensity aerobic training compared to a more moderate intensity training. So it suggests that you need some high intensity exercise to get the best benefit. Now, that's not to say that, doing lower intensity exercise isn't also beneficial, just maybe not quite as much. And so now the SPARKS 3 study is currently enrolling participants who are newly diagnosed and not yet on medications, and doing treadmill exercise in those participants over 18 months. Some of the research related to weightlifting and resistance training also shows not only that it helps symptoms, but can actually lead to physiologic changes. So this study looked at muscle biopsies in people with Parkinson's before and after an exercise intervention and compared that to control participants. And you can see the picture of the muscle biopsy itself, and the controls are on the left side of that 3-panel figure, and then the PD patients before they started exercise and then after exercise. So they actually had muscle biopsies more than once, which was very brave. So the dark fibers, those dark color fibers, are the ones that are not very helpful. And the green fibers are the more efficient muscle fibers. And so those increased after exercise in Parkinson's, and even increased more than what was present in the control participants who were younger but not exercising. So that's the middle thing in the bar graph. It shows that gray band is higher in the Parkinson's patients after exercise. So it can actually change your muscle fibers and make you stronger and more efficient in your movements. So we'll move on and talk about the non-motor symptoms. And this is really the area that I'm most interested in as far as my personal research. And hopefully we can get you all up and encouraged to get moving if you're not doing that already. So what about exercise and mood in Parkinson's? So there are not too many studies looking into this, but the studies that have been done, many of them do show improvement in mood with exercise. So in Parkinson's, depression can improve with aquatic therapy, aerobic exercise, combined intervention with both aerobic and resistance training, and also with a study that's exergaming. So I think that's probably like the Wii games. And then there have been a few small studies that showed no improvement in mood with exercise. But again, if you do a meta-analysis looking at a combined set of studies and combining all the data together, it does show an overall beneficial effect of exercise on mood. And that's not too surprising because we know that happens in healthy older adults as well, but it can help with mood to do exercise. And what about cognition? So I'll talk a little bit more about cognitive dysfunction in Parkinson's. So unfortunately, it is a common side effect of the disease progression, and it can have significant implications, of course. So if cognition is severely impacted, it can lead to loss of independence, loss of being able to drive, and things like that. It also can impair function at work and at home. And sometimes people have to retire because of their cognitive problems. If you have cognitive trouble and can't take care of yourself as well, you have to have increased caregiver needs. And so unfortunately, that can lead to increased risk for institutionalization or having to get increased nursing help. And then you can also have some apathy, like I mentioned before, that loss of motivation can come with cognitive impairment, and impairment of quality of life, of course, because it just makes things change on how you can interact with the world. So what does exercise do for cognition? So in healthy adults, we know that it can it can improve performance on tests of memory, tests of attention, processing speed, and executive function. So these are multiple different domains of cognitive problems, many of which can affect people with Parkinson's. So exercise can help all of those. And if you do a lot of exercise in your middle age years, it reduces the risk of development of dementia or mild cognitive impairment. So it's got a protective effect as well. And then if someone is diagnosed with severe dementia, it can actually help improve your cognitive symptoms if you start exercising. And there was one particular study that was done in a group of nursing home patients with very severe dementia, and they actually had improvements in cognitive performance with the exercise intervention. So it can really make a difference no matter how advanced your Parkinson's or your cognitive problems are. And why does this happen? So what is the physiology of what's going on? So exercise can actually increase your brain volume, and it does that in areas that are important for memory, like the hippocampus. It also can reduce risk factors associated with dementia, like heart disease or cardiovascular disease. And then it also increases production of neurotrophic factors. There's one that's called the brain-derived neurotrophic factor, or BDNF, and exercise actually increases that, and that can help with cognitive function. So what about specific to Parkinson's disease? So there have been several studies showing that exercise can help improve cognition and PD as well. So adapted tango, there's a great intervention for Parkinson's that involves dance. And it's adapted because it's made a little bit different for people who have trouble with balance. And that can actually improve visuospatial function. I don't know if many of you have heard about the passive cycling, where being on a tandem bike with someone in the front who's controlling the pace of the pedaling and the Parkinson's patient on the rear, and being made to pedal at that same frequency. And that can improve executive function. Aerobic exercise also can improve executive function. And then resistance training or weightlifting can improve lots of different things. So attention, memory, and executive function as well. And executive function is often a big problem in Parkinson's. It's more than, like, for example, memory is a problem more in Alzheimer's disease. So executive function is your ability to carry out and complete a task or plan a task. So you used to be able to assemble an engine, and now you can't remember which steps go in which order. All right, here's my favorite topic, sleep and Parkinson's, and how exercise affects that. So sleep is sort of a mysterious thing. For many, many years, we didn't know why people sleep. It was for a long time thought to be just, a time to rest. But so many active things happen during sleep. Our brain is very active. Our body is very active. We have different hormones that change through the course of sleep. And if we don't get enough sleep, all of that can be in error and not work the right way. So we think about sleep in two different large categories. There's the non-REM sleep, or non-rapid eye movement sleep, and REM sleep. So non-REM sleep includes three different stages. There's the lighter stage of sleep, which is called N1. There's N2, which takes up most of the night. And N3 is also called slow wave sleep. And that's actually our deepest and most restorative stage of sleep. And then REM is also called paradoxical sleep, because this is when our brain is really, really active at night. And this is when we tend to dream. And importantly, this is when our muscles also should be paralyzed. But of course, in Parkinson's, that can come out as loss of paralysis of dream sleep, which leads to the REM sleep behavior disorder, or acting out dreams. During the deep slow wave sleep, we have really regular heart rate and blood pressure and respiration rate, but that's more irregular during REM sleep. And this picture here is what's called a hypnogram, and it's a diagram of how sleep is supposed to be during the night. So this is what would be normal sleep. So you can see when the line is at the very top, that's when someone's awake. And as it progresses through, the black colors are non-REM sleep 1, 2, and 3. And you can see non-REM stage 3, or that slow wave sleep, is more prominent in the early part of the night and decreases as the night progresses. And then the green bars are our REM sleep, which increases in duration throughout the night and is supposed to occur about every 90 minutes. But in Parkinson's disease, oh, my picture's not there. Maybe it will be later. Sorry, I'll get to that. In Parkinson's disease, it looks a little bit different, unfortunately. So in Parkinson's, we can get sleep fragmentation, which is also called sleep maintenance insomnia. So you might fall asleep well at the beginning of the night, but you just wake up a lot and can't stay asleep. And then, as I mentioned, the REM sleep behavior disorder, and we'll talk more about that too. Excessive daytime sleepiness can happen in Parkinson's, and that can be either because you're not sleeping well at night, but it could also be because you have changes in the brainstem, in the area of the brain that's responsible for keeping you awake and alert. So that's called the ascending arousal system, and it can undergo neurodegeneration just like the substantia nigra, where the dopamine is. And so that can lead to daytime sleepiness, even if you sleep a lot at night. And then, of course, Parkinson's disease is a disease of getting older, right, in general. And there are lots of disorders of sleep that also happen with getting older. One of the most common is sleep apnea, which can certainly affect people with Parkinson's. And people with Parkinson's who have sleep apnea tend to have a little bit different symptoms. Like they might have daytime sleepiness, but not really snore that much, but still have sleep apnea. So it's important to check for those things. And then, of course, things like restless leg syndrome and periodic limb movements of sleep. So sleep fragmentation is 3 times more common in Parkinson's than it is in healthy aging. And, we all sleep a little bit worse as we get older, but that's even more pronounced in Parkinson's. And it can take longer to fall asleep, make you wake up more often, and you get a decrease in that deep sleep, that non-REM stage 3, and also a decrease in REM sleep. And here are the pictures I was looking for before. So here's our healthy adult again, and these are a couple of my Parkinson's research participants who had a really disrupted sleep at night. So you can see the first participant went to sleep really quickly, but then woke up a lot all through the night. Very little bit of non-REM stage 3 sleep and really delayed REM sleep. And then the second participant, they took a really long time to fall asleep and had lots of awake periods through the night. And again, just really fragmented. So what causes us to wake up when we have Parkinson's? So it can be the motor symptoms. So if you have rigidity and slowness of movement, it can make it hard to roll over in bed. So whereas I might wake up because I feel uncomfortable during the night and I just roll over and go back to sleep. But if you have Parkinson's and you have to have your bed partner assist you in rolling over, or it takes a lot of work to roll over, then it gets your heart rate up and you're wide awake after that. Tremor goes away during sleep, but if you have a small microarousal, it can reemerge and come out. And so that can lead to awakenings too. And dystonia. Does anybody have dystonia that wakes them up during the night? It can be really painful, toe clenching or toe extension. And this is a picture of a dystonic toe. And so that can be painful and wake people up during sleep. And I mentioned earlier, autonomic function or dysfunction is one of the symptoms of Parkinson's sometimes. And so that can make you have to pee a lot more at night. Depression associated with Parkinson's can make you wake up earlier in the morning. And then cognitive problems can make people confused during the night or lead to sundowning in the evening, and so can disrupt sleep in that way too. Medications like levodopa can actually cause some insomnia. For some people, it helps them sleep because it helps their motor symptoms, but in others, it can actually cause them to not sleep quite as well. And then the changes in the brain that I mentioned earlier. So we have neurodegeneration, and that can lead to changes in certain areas of the brain that are important for inducing sleep. So REM sleep behavior disorder. We've talked about this several times today. So again, this is acting out dreams, and it can lead to injury for the patient or the bed partner. I've had people who've told me that they've dived out of bed and knocked a hole in the wall with their head. I had another patient who punched a glass bookshelf and had to have emergency surgery because he had opened up his radial artery. So it can be very dangerous and also very disruptive to good sleep quality. So this is how we look at a sleep study. This is a 30-second period of time, and it's a little bit small, but about halfway down the page, there's a line that says EMG, and there's one that says legs, and you can see there's not much activity there. They're quiet. But in REM sleep behavior disorder, you lose that paralysis of dream sleep, and it allows acting out of dreams. And so you get the movements during dream sleep. And those top 2 lines are our eye movements. So you can see those rapid eye movements as the lines go away from each other. And interestingly, REM sleep behavior disorder is a big area of research because it does predict development of later development of Parkinson's disease. So that's why the PPMI study is focusing on that as recruitment of patients. So I have a couple of videos. One of these is a little bit of a violent video, so I'll tell you when that one's coming if you don't feel comfortable seeing it, but nobody gets hurt or anything, but it's just some violent movement. So this is a patient who's in REM sleep, not the violent one. It looks like he's just climbing or something. All right. And then there's another example that shows that acting out dreams isn't always violent. So this guy is kicked back, having a good time, it looks like. So that light on his finger is his pulse ox. So that's his oxygen monitor. He looks like he's just smoking a cigarette. Tossed it on the floor. All right, so as you can see, REM sleep behavior disorder isn't always violent. A lot of times people describe that their dream enactment is related to what they did in life. For example, I had a professor who told me that he would lecture during his dreams. And another patient with narcolepsy, which is also associated with REM sleep behavior disorder, she worked at a coffee shop and she would have a tray, like, pretend like she was carrying a tray. So it's not always violent. But this next video shows some somewhat violent behavior. And so close your eyes if you're not comfortable. But wearing CPAP. So that's what that is on his face. So sometimes these behaviors can be really violent. And so it's important to think about making sure that the bedroom is safe. And so we always tell our patients, no weapons in the bedroom, particularly no loaded guns, certainly. And if you do have guns in the house, make sure that the weapon is locked up and not loaded. Sometimes you have to move tables and lamps away from the bedside because people might punch during their sleep and can injure their hand. We sometimes have to put the bed partner in a separate room. And many times I see patients who've already made that step before they ever get to the doctor. Sometimes having padded bed rails, or if people are rolling out of bed or diving out of bed, having a mattress on the floor or at least some sort of padding next to the bed if they do fall out of bed, or even sleeping in a sleeping bag. So that can sometimes work. Of course, we did mention earlier a little bit about melatonin. And so melatonin can suppress dream enactment behavior. And there was a question earlier about how do we dose the melatonin. And I usually start at 3 milligrams about 30 minutes before the typical bedtime. And then let that be tried for about a month and then increase it from there if needed. Again, I don't usually go above 10 or 12 milligrams. There are other medications that can also suppress dream enactment behavior. So even though these safety changes are important, that's not the only steps we take. So sometimes we don't think about it, but yeah, don't leave a hammer or a pair of scissors or something on the bedside table because that can also be really dangerous. So another sleep problem in Parkinson's is excessive daytime sleepiness. It's also really common, and it can be related to medications, especially like the dopamine agonists are known to make people sleepy and were reported in some cases to even cause unexpected sleep, like sleep attacks. And of course, all of this can lead to risk of injury or drowsy driving and can impair your ability to interact with your friends. Because if you're falling asleep, you might not go out and interact. And it can, of course, impair getting sleepy at work. So let's talk about how exercise affects sleep. So I mentioned earlier, this is the area that I'm really interested in, and this is what our research focuses on. So exercise, we know, has beneficial effects on sleep in healthy older adults, but it's also been found to have good effects on subjective sleep quality, meaning how people feel about how they sleep. So people feel like they sleep better when they exercise. But there were originally not any studies looking at whether that actually improved sleep studies in Parkinson's. So could we actually look at those hypnograms and see that people sleep better after doing an exercise program? And this another meta-analysis here that I'm showing that this diamond favors exercise, meaning that sleep gets better in the people who exercise. So we did a randomized controlled clinical trial looking at how exercise affects the sleep study in Parkinson's. And we had Parkinson's patients who were in an exercise group, and there were 27 of those, or a sleep hygiene group where we talked with them about ways to improve their sleep habits. And those were 28 in that group. And so the exercise was a weightlifting, high intensity resistance training that happened 3 times a week for 16 weeks. And then all participants had a sleep study before and after the exercise intervention. And so we saw that the exercise significantly improved a lot of types of sleep, or a lot of areas of sleep, excuse me. So sleep efficiency was our primary outcome. And this is the percentage of time that you're in bed that you're actually sleeping. And so that improved a lot in the exercise group. And so exercise group is on the left of this chart and not the sleep hygiene group on the right. And then we also saw a reduction in the minutes awake after sleep onset. And the line goes up because we wanted to make all the things rising being good. So we had multiplied that wake after sleep onset time by -1. So higher is actually better in the graph. It also increased the total sleep time, and importantly, it increased the minutes of slow wave sleep, or that non-REM stage 3. So as I mentioned earlier, non-REM stage 3 is predominantly in the beginning of the night, and it is, we think, very important for cognition. So there's a relationship between sleep and cognition and Parkinson's. And again, we'll focus on this non-REM stage 3 or deep sleep. And it's important for memory consolidation in non-PD populations and can help with synaptic plasticity. It's also been shown to increase clearance of neurotoxins from the brain. And if you selectively disrupt this stage of sleep, it can worsen cognition. And if you enhance it with special techniques, it can actually improve cognition. So it's very important for cognition overall. But that has been found in healthy people. So we wanted to find out what happens between slow wave sleep and cognition and Parkinson's disease. So we had people do a sleep study and a really extensive cognitive testing evaluation. So we had at least 2 tests in 6 different cognitive domains. So those were executive function, like I mentioned earlier, attention working memory, visuospatial function, language, and processing speed. And we found that the people who had higher than the normal or higher than the regular amounts of expected slow wave sleep for age had better performance on the cognitive testing. So we look at the composite cognitive score, which averaged all those domains together. They had a greater than 0, which is better than normal cognitive performance. Whereas the people who had low amounts of slow wave sleep had -0.22 or less than normal cognitive performance. And then when we looked at each of the individual cognitive domains, there was also a significant difference in the high versus low slow wave sleep in the people and in performance on executive function and language function and processing speed. And then the people who had more slow wave sleep were less likely to be diagnosed with Parkinson's disease, mild cognitive impairment. So overall, just had better cognitive performance. So in summary of the research that we've done, we've found that exercise increases deep sleep and that deep sleep is associated with better cognitive performance. So now we're trying to find out how does exercise affect sleep and cognition. And so Dr. Heffernan mentioned this study now that's recruiting. It's called Excites PD, which stands for Exercise-Induced Cognitive Improvement Through Enhanced Sleep in Parkinson's. So our goal is to see if we can have people exercise and improve their slow wave sleep, will that also improve their cognition? So that study is going on now, and there are flyers out there, and we really would love participants. All right, so switching gears a little bit, we'll talk briefly about diet, because we get these questions a lot in the clinic. What are healthy foods that should be eaten? And so there's some evidence for both the Mediterranean diet and also a formulation of that called the MIND diet, which stands for Mediterranean-Intervention for Neurodegenerative Delay. So the Mediterranean diet, there was a large research study of more than 41,000 people that showed that this diet reduced the risk of developing Parkinson's and might make symptoms milder when it did develop. So it might delay the age of onset of Parkinson's and may improve cognition as well. And then the MIND diet also has been shown to possibly reduce the risk of Parkinson's or delay the onset of it. And then one study compared these two diets and found that people in the MIND diet had fewer PD symptoms. So it might be a little bit better. They're similar in some ways, though. So here is what they are. So the MIND diet, there's a shopping list here, but basically it encourages you to eat more green leafy vegetables in general, berries or those power fruits, whole grains, beans, nuts, poultry, fish, and olive oil, and focusing on the healthy fats, like the ones in types of fish like salmon and tuna. And then, and wine is listed there too. So that's in moderation. And then you should reduce or limit red meat, cheese, butter and margarine, fried foods, and sweets. So things that are processed. So that's the MIND diet. All right. And then just a few recommendations for healthy living in general. So as I mentioned, sleep is a problem in Parkinson's, but it's also a problem in lots of people. So hopefully everybody can get some benefit from these suggestions, but really important to maintain a consistent bedtime and wake up time. Now, it can be hard to do this if you're not feeling sleepy. It's hard to go to sleep. But if you maintain a consistency, then your circadian clock that's in your brain knows what to expect. So from the caveman times, we were used to being awake when it's daylight and being asleep when it's night. And we can confuse those things now with electricity and our telephones and things. But it's good to try to maintain consistency so that our brain will know when it's time to fall asleep. Also avoid reading, electronics, and TV in the bedroom. So basically any activities other than sleep or sex should not happen in the bedroom. It's okay to clean occasionally, but don't hang out in your bedroom, and especially not in your bed. That we want, again, to train your brain that when you're in bed, you sleep, and that's what you do there. It's important not to watch the clock. This can be really stressful. So you glance at the clock and after you've woken up and realize, oh my gosh, I've only been asleep for an hour. Or, oh no, I've only got 1 hour left to sleep. Or here we go again. I'm waking up every hour all night long. So that becomes stressful, and stress is not good for sleep. So just turn the clock so you can't see it. Don't look at your phone during the night to look at what time it is, and just ignore what time. Set your alarm. You'll wake up when you have to. The other important thing is to get out of bed if you can't sleep. Now, if you have significant balance trouble and it's unsafe to get out of bed during the night, then this is not the right step for you. But if you can still get up safely, put some night lights along the path to your living room and leave the bedroom if you're not able to sleep. Now, this should happen you don't wake up briefly and jump out of bed because you're awake. But when you get to the point where you're frustrated about not being able to sleep, then you don't need to stay in bed, because then you associate your bed with a frustrating place. So leave your bed if you're unable to sleep, and don't do any daytime activities during the night. So don't be productive, even though it's tempting to do so. So when you get out of bed during the night, your goal is to get back sleepy again and go back to bed. So don't clean the house, don't work, definitely don't pay bills, don't do anything stressful. So get up, maybe sit on the sofa, stare at the wall, read a boring book, not a page turner. You want to be able to put it down easily. You can watch TV if you have to, out of your bedroom. Don't watch an action movie. Do something that's boring that's going to hopefully get you back to sleep. And then you can do some sleep relaxation techniques like progressive muscle relaxation. And there's a phone app called Cognitive Behavioral Coach for insomnia, cognitive behavioral therapy for insomnia coach. So CBTI coach that talks about some of these relaxation techniques. And there are other things that you can look up online, but sleep relaxation can be helpful. Minimize alcohol at night. Even though it can make you drowsy when you try to fall asleep, as it wears off through the night, it will lead you to wake up and have a hard time going back to sleep. And then remember always to never drive drowsy. It's very important. Drowsy driving is worse than drunk driving. And exercise can help with sleep as well, as we've talked about. So speaking of exercise, how much should you do? So the World Health Organization recommends that you exercise at least 150 minutes per week and plus 2 days of of resistance or weightlifting. So 150 minutes per week is about 30 minutes, 5 days a week. And so that can be pretty achievable. You don't go from nothing to immediately to that, but you can work up to it. The other important thing is do exercise that you enjoy. Even though I talked earlier about the importance of high intensity exercise, if you hate high intensity exercise, don't try to go run a marathon. So try to do something that you'll continue to do. And also, it's really helpful to have an exercise buddy. So if you have someone that you usually meet at the gym, then you'll know that they're expecting you to be there. So there's some accountability there and you're more likely to show up so you won't disappoint that person. And think of exercise as a prescription from your doctor. It is just as important as your medications. So I said some of this already, but some activity is better than none. So if you can't get yourself to do 30 minutes, 5 days a week, at least stand up and walk around the house every hour. Do something to get up and get moving. And I tell almost every patient I see about the floor cycle. I have one under my desk at work. It's just something you can pedal, and you can put it in front of your chair and pedal every time a commercial comes on, whatever show you're watching. You can get going pretty fast. You can pick it up, put it on the desk and pedal with your arms. So do something to be active and keep moving. And also do some things to help with balance and talk to your doctor about things that you might need to adjust. So I wanted to show a picture here of my research group from the place I moved from before here these people did a lot of the work that I presented today. And I really love the research group here too. And you can meet a lot of them out at the tables. And thanks for your attention. I'm happy to answer questions.